Hello, my name's James O'Mahony. I'm a health economist at Trinity College Dublin, and today I want to give a presentation on something I've been working on recently. It's a commentary article on the forthcoming pricing and supply deal that the state is due to renew with the pharmaceutical industry in Ireland. Now, this agreement is important because it's likely to set the cost effectiveness threshold for Ireland, which is important for deciding the pricing of new drugs and what interventions are and are not reimbursed. Now, this presentation is not primarily a health economic technical presentation, but rather it dwells on the policy significance of the threshold and the deal used to set it. So, given that you may not stay and watch the whole presentation, I just want to give you the three main points at the outset. First of all, the current threshold of €45,000 per QALY is too high, probably relative to opportunity costs in Ireland. Therefore, the threshold seems likely that it needs to be reduced downwards. We also can't really see how meaningful the cost effectiveness threshold is because we don't have data on the actual prices or ICEs on reimbursement in Ireland. Thirdly, the current threshold doesn't seem to satisfy the requirements of the 2013 Health Act.
This article has not yet been peer reviewed. You can find a link to a preprint in the description box below.
So I just want to give an overview of the presentation. First of all, I want to talk about the context of existing pricing and supply deals that have been agreed in the past and the new deal that's due this summer. I then want to talk briefly about the Irish healthcare system and previous criticism of the cost effectiveness threshold. I then want to consider some of the institutional and political considerations around reform of the cost effectiveness threshold. Towards the end, I want to briefly ask, should we be using a cost effectiveness threshold at all in drug reimbursement? Then I'll do a brief summary of what I think needs to change, and I'll present my conclusions. So to give some background on the pharmaceutical pricing agreements that have been used in Ireland in the past, the Irish Pharmaceutical Healthcare Association, or IPHA, is a trade body that represents the interests of manufacturers of patent protected medicines in Ireland, and they have agreed a series of deals with the state going back decades. The most recent of these two deals in 2012 and 2016 have both defined the cost effectiveness threshold to be used in Ireland. Both these agreements set the cost effectiveness threshold at €45,000 per quality adjusted life year, or QALY. Now, the 2016 deal has some additional detail in that it stated two thresholds. It also stated a lower threshold of €20,000 per QALY. However, I would question how relevant this lower threshold is, as any drug that is rejected at the lower €20,000 per QALY threshold can simply be sent back to a higher decision-making level within the health service executive for consideration at the higher level. So ultimately, it seems that the higher cost effectiveness threshold of €45,000 per QALY is ultimately the relevant threshold. A new IPHA deal was due in July 2020, but it was postponed due to the pressures of COVID-19, and it's now due to be agreed this year in 2021. It's important to acknowledge that Ireland has no formal exceptions to the point threshold that's used. So we use a point threshold of €45,000 per QALY, but a point made to me by Dr. Valerie Walsh of the Health Services Executive a number of years ago was other countries tend to have formalised exceptions to the standard threshold. So for example, NICE in the UK uses a standard threshold range of £20,000 to £30,000 per QALY, and they state some criteria that are useful in informing decisions within that range, and they have an additional set of criteria. Those include the end-of-life criteria, which permits a threshold of up to £50,000 per QALY in certain circumstances. There has been the Cancer Drugs Fund first and second iteration of those to fund drugs that haven't proven to be cost effective relative to the standard threshold range. There's also been the acceptance of non-standard discounting in specific cases. And more recently, we've had the highly specialised technologies criteria, which provides cost effectiveness thresholds of between £100,000 and £300,000 per QALY for certain technologies. It's also important to acknowledge that other countries use various forms of severity weighting to various degrees of explicitness, and Ireland doesn't have any of these formalised exceptions, so that's important context when we think about the current threshold in Ireland. I now want to consider the context of Ireland's current healthcare system. So many of you familiar with the Irish healthcare system and health services research here will know that we have this mixture of public and private provision. Approximately 1/3 of the population are eligible for care that's free at the point of use, an additional approximate 40% buy private health insurance. Now, the public health system tends to feature large waiting lists for elective services, and this forms part of the incentives for those who have means to purchase private insurance. Some nice work recently by Brick and Connolly has done some analyses of comparisons of waiting lists in the between OECD country members, and they find for a comparable set of interventions, Ireland tends to have longer waiting lists than our nearest neighbours in the UK. So just to quickly go through some previous critique of the cost effectiveness threshold. So Brick and colleagues back in 2013 queried if Ireland's cost effectiveness threshold was at the right level. And they didn't go into a lot of detail, but they did note that the threshold was higher relative to the threshold used in the UK. They also drew attention to breaches of the cost effectiveness threshold where drugs that were cost ineffective relative to the threshold had still been reimbursed. And they also questioned if the threshold should be set in a deal with industry rather than being determined independently by the state. In 2015, I wrote an article with my colleague Dermot Coughlin critiquing the threshold somewhat further, and we noted 4 problems. First of all, that the EFA threshold only applies to drugs. There's no explicit non-drug threshold for use in Ireland. Also, the threshold represents a price floor, not a ceiling, and a price floor is a guarantee of a minimum price, not a control on the maximum price. So this doesn't seem a very good control in order to ensure good value for money for the healthcare system. Importantly, the threshold doesn't seem to be based on any evidence of opportunity cost, and that's significant, and I can consider that a little bit further on a further slide. It also seems likely that the cost effectiveness threshold is too high, and again I'll consider this further on a following slide. Just to note that Gurecki echoed some of these concerns in 2017, stating that the drug spending was probably too high relative to other uses of healthcare funding. So just to give some further consideration to the claim that the cost effectiveness threshold that we use in Ireland is probably too high. Well, in that O'Mahony and Coughlin paper, we drew attention to 3 kind of sentinel interventions of hip replacement, knee replacement and cataract removal, as these are interventions that all have very large waiting lists within the public system. When we look to UK estimates of cost effectiveness, we find cost effectiveness ratios of between about 2,000 and just over 5,600 pounds per QALY. So these seem very highly cost effective interventions, yet that they're not provided with good access within the Irish healthcare system. Now, accordingly, it's not rational to maintain a very high threshold when there's such unmet need for highly cost-effective services such as these. So this is part of the rationale for advocating for a moderation in the cost-effectiveness threshold and therefore to devote more resources to addressing the unmet need for elective services in Ireland. And then an analysis that was done more recently by Chen et al., I was a co-author on this paper, looked at the top 20 interventions on waiting lists in Ireland and assessed evidence of their cost effectiveness. And the yellow bars below the line here represent the waiting list size for these 20 interventions. The blue bars above the line represent estimates of cost effectiveness taken from the literature, and we can see the solid red line represents the current cost effectiveness threshold of 45,000 euros per QALY. And what we can see there is that cost effectiveness estimates taken from the literature of these interventions, many of them are far below the threshold. So that adds to the concern that our current threshold is probably too high and needs to be reduced if it's to be brought into better alignment with estimates of opportunity cost. I now want to consider some of the legal requirements of the 2013 Health Act. So the Act doesn't mention a cost effectiveness threshold. However, it does mention cost effectiveness in terms of opportunity cost, and that is significant because it clearly conceives of cost effectiveness in the same way that most health economists do when we think about opportunity costs. Now, the Act doesn't place any requirement on the Health Service Executive, the HSE, which is the body responsible for implementing public health services in Ireland. It places no requirement on the HSE to reimburse cost-effective interventions. Rather, the HSE only has to give regard to opportunity costs. Now, I would argue that as the current cost-effectiveness threshold of 45,000 euros per QALY doesn't relate to opportunity costs within the Irish healthcare system, then I would argue that that threshold doesn't permit the HSE to give regard to them. So I think the current threshold, as is set in the 2016 EFA agreement, is inconsistent with the 2013 Health Act. Now, I'm not a lawyer, so I don't really understand the legal significance of this, and I can't really imagine anybody would bring a challenge, but I think it is notable that we have an inconsistency between a major policy tool, the cost effectiveness threshold, and the very clear legislative basis for the use of cost effectiveness analysis in Ireland. I want now to talk a little bit about transparency regarding how the threshold is set. So in principle, the threshold, if it was applied properly, should determine how hundreds of millions of euros of public money is spent annually. I think it's notable that the basis on which the 2016 threshold was agreed is not clear, and I don't think there's any documentation explaining why they chose that threshold value. And also that threshold was agreed behind closed doors is notable. So there's no transparency from the outside to understand why this threshold was agreed at that level and who informed those discussions. And I also think this lack of transparency is notable given that Ireland is a member of the Open Government Initiative, which is an international collaboration which aims to improve transparency in government in general. And one particular part of that is greater transparency regarding resource allocation. So I don't think we're doing very well given the spirit of the Open Government Initiative. I also want to talk briefly about transparency regarding adherence to the threshold. So we have an issue that there's limited transparency regarding the prices or the incremental cost effectiveness ratios, those ICEs, of drugs on reimbursement once they're approved. So the list prices aren't necessarily the reimbursed prices. And when the National Centre for Pharmacoeconomics, the NCPE, publish their health technology summaries, they only do those for those interventions that have gone through a full HTA review. No summaries are published for those drugs approved following a rapid review. And in general, the ICEs on reimbursement aren't published, so we don't understand when the cost effectiveness threshold is being broken or not. So we don't know how often the threshold is being breached, and we don't know by how much. As a consequence, we do not know how meaningful the threshold is, and we don't know what factors influence deviation from it. So now I want to think about some of the political considerations that might influence the prospects for reform of the cost effectiveness threshold. So cost effectiveness is widely espoused in the abstract, in particular by politicians. It seems like a good thing that we would want to have cost-effective healthcare services. But when we find individual instances where cost effectiveness means that we're going to have to reject a cost-ineffective intervention for an identifiable patient group, those rejections are politically unpalatable, and politicians understandably won't want to be associated with those rejections. Improving access to elective services may be expensive, so there's some nice work done recently by Brick and Keegan from the ESRI looking at what it might cost to reduce Ireland's healthcare waiting list for elective services, to initially reduce the lists and then to keep them at a sustainably low level. And they show that it will be quite expensive to do that. And voters may be, to a degree, used to waiting lists, so whether or not they factor in the benefit of improvement in healthcare services to reduce these waiting lists, it may not matter much because they may just be used to the long waiting list that we see already. Furthermore, those individuals who can purchase private health insurance, they may see that their interests are better served by the status quo. It might be cheaper for them simply to purchase their own private health insurance rather than to support reforms that would require improved public services to deal with the elective waiting lists, which would require presumably increased taxation to generate the additional funding required. So all in all, I think reducing the threshold to improve the balance between drug spending and the current unmet need in elective care may not be a vote winner. I would also like to consider some of the institutional incentives around threshold reform. So Ireland in recent years has got increasing health economics capacity. The National Centre for Pharmacoeconomics has increased its staff recently. HICWA likewise has a growing number of expert health economists. They support the National Clinical Effectiveness Committee, the NCEC, which considers cost effectiveness as part of its deliberations. And also the Health Research Board SPHERE programme is training more and more health economists to the doctoral level. And we also have other trained specialists in other related areas of health services research. However, increased analytical capacity, I would argue, doesn't necessarily mean that we get better resource allocation. In fact, we might just have greater awareness about the problems of misallocation that we currently have. Also, I think it's important to recognise that a lot of the health economics expertise is concentrated at the NCP and HICWA, but neither of these bodies has an overarching remit for the balance between drug and non-drug interventions. Neither body has a role in setting the threshold. And I think that's important because they're the bodies that have got, within the state, that have got important health economics capacity, but they're not responsible for setting the threshold. And I think that policy responsibility most naturally lies at the Department of Health. But the problem there is that they do not have the concentration of expertise that the other bodies mentioned do. So I now want to briefly consider the issue of technocratic pushback. So we can see that the political incentives around reimbursement might naturally be in tension with the technocratic principles of cost-effectiveness analysis. Politicians might want to reimburse interventions even though they might be cost ineffective. We've seen that politicians have overruled rejections of cost-ineffective drugs in the past in Ireland. And so the question is, how hard should technocrats attempt to push back against political dilution of cost-effectiveness analysis? And it's notable that Professor Michael Barry, the head of the NCP, has already done this to a degree over pembrolizumab. However, I'd have sympathy with technocrats if they didn't push back very hard, because I think there's a fine line between defending the technocratic processes and getting involved in policy discussions and advocacy to a degree. And consequently, I think the incentives to confront politicians may be weak. I think if you attempt to take on politicians, you can damage your own career prospects, and you may also bring the institutions that you work for into conflict with elected politicians, and I think that is potentially problematic. I want to briefly mention the impact of COVID. So COVID, of course, has exacerbated the existing problem of unmet need within the Irish healthcare system. So waiting lists have got even larger as services were cancelled throughout 2020 and then in the early portion of 2021. And also, not only have the waiting lists grown larger, but individual patient needs may have grown more acute in that period as problems weren't seen at an early stage, and in many cases, sadly, will grow more grave in their severity. We also have additional spending challenges for both health budgets and government spending in general. So in 2020, there was an additional 14.1 billion euros for government spending overall that was allocated in response to COVID, and there was an additional approximate 2 billion allocated for health. Now, these very large amounts will be attenuated over time through borrowing, and we can do that currently at low borrowing costs, but these absolute amounts still are large. There is definitely an additional pressure on healthcare spending at the moment due to the large amount of money that was spent on COVID measures. Now, I want to very briefly question whether or not we should be using a cost-effectiveness threshold in drug reimbursement at all. So the current approach commits paying our maximum willingness to pay for a QALY, and this leaves very little scope for capturing welfare for society. We typically only maybe get a welfare benefit when a medicine is priced comfortably below the cost effectiveness threshold, or when the patent expires on that medicine and the price drops. Also, we may have the problem, as I've outlined earlier on, that we may have the wrong threshold. So if we're pricing at the threshold but we're setting the price too high, we're likely to be making consistent damage to the healthcare system. I would like to propose an alternative auction-based process which uses sequential funding rounds. In this process, a number of candidate interventions will come forward following approval by the EMA, and they'll be seeking reimbursement in Ireland. And funding will be granted to those drugs that offer the lowest cost per QALY first, and reimbursement will be made until the new round of funding is exhausted. Any drugs that didn't achieve reimbursement will be rolled over to the next round, and they will compete with the new interventions that will have achieved EMA regulatory approval, and they'll compete in that round. Now, some disadvantages of this process: it will mean that there will be some slower reimbursement, and there'll be some greater need for planning to plan these funding rounds. They might be these funding rounds might occur, say, quarterly. I would note, though, that delay in reimbursement is only really a problem if it's delaying the reimbursement of cost-effective interventions. The optimal timing of a cost-ineffective intervention is never, and if it's delayed somewhat, that's not a bad thing. this auction-based approach would create an incentive on the manufacturers to actively bid down their cost per QALY somewhat below the cost effectiveness thresholds that we use currently. Now, this proposal is clearly beyond the scope of any new deal due in July. However, I do think it's worthy of consideration for future rounds. So I just want to consider overall what needs to change, and this is my own personal view. So I think the Department of Health needs to take leadership, and it needs to set the threshold independently. It needs to set the threshold in accordance with opportunity costs, and as I've outlined earlier on, that probably implies a reduction in the cost effectiveness threshold. And if we are going to have deviations from the standard threshold, I believe those should be formalised, made explicit, and that they should be supported by evidence. I also think that we should seek greater transparency on prices on reimbursement. Now, I think that this is possible without compromising commercial confidentiality on the prices or ICEs of any individual products. So I think what we could do is we could use some aggregated reporting of the ICEs and budget impact of sets of interventions. If we aggregate the information sufficiently, we can still preserve commercial confidentiality on the prices and ICEs of individual products, but we can provide greater transparency on the number of interventions that breach the threshold and what are the budget consequences of those breaches. And I think that would be important because it would provide greater accountability for policymakers in the allocation of scarce healthcare resources. So in conclusion, I think the lack of an evidence base for the cost effectiveness threshold really needs to be addressed. And I'd just like to make a little emphasis on this here. I think we like to think of cost effectiveness analysis as fitting into the evidence-based medicine paradigm. And sure, we do consider the evidence regarding the costs and the effects of individual interventions. But if the decision rule that our cost effectiveness ratios are compared to is not based on any evidence, then I would argue that the decisions that come about from the combination of cost effectiveness ratios and the cost effectiveness threshold is not in any way evidence-based. And I think we need to address that. So it seems pretty clear to me that a reduction of the threshold is necessary given what we see in terms of opportunity costs and the additional pressures from COVID. However, I think we need to be realistic about the prospects for reform of the threshold, especially when we consider some of the political and institutional incentives around reform. And given that some individual institutions, even though they might have the expertise, don't appear to have the remit to inform how the threshold should be changed, I think it's up to the Department of Health to take leadership on this issue. So thanks very much for your attention to the presentation. The link is available to the preprint document, so please do take a look at that and do get in touch if there's any comments that you would like to make. I've also posted this on Twitter, so if there are any comments, that might be a good place to have a conversation. Anyway, thanks again.